Welcome everyone to our Ask the Expert session with the Salt Lake City team. We are very excited to have you here today. I believe this is our fifth Ask the Expert session of the year featuring our law enforcement mental health learning sites. We are very excited to have you all here today. We are going to be learning about the Salt Lake City Police Department's work with the Community Connection Center. Before we get into things, we're going to just start with a couple of quick introductions. Those of you who have been on these Ask the Expert sessions before probably recognize me. My name's Ethan Aronson. I'm a senior policy analyst here at the Council of State Governments Justice Center. I do technical assistance work with grantees across the country, but another big part of my work at the Justice Center is working with our 15 law enforcement mental health learning sites. These sites are agencies that have been identified by BJA and my organization as being really at the forefront of this space, law enforcement and mental health collaborations. So people who've been doing this work a long time, people who've built out really robust programs, and they are wonderful enough to offer their time to people like you to share their experience, share their expertise, and to do a little bit of peer learning on our behalf. So we're very grateful to the learning sites, all of them, for their assistance on our project work, on our grantee work, and of course on events like this. So the session is going to be 90 minutes. We're going to have a quick introduction by the Salt Lake City team, and then we are just going to open this up for questions. We're not doing any slides or anything like that. So if you have questions, feel free to use the raise hand function to type it into the chat. Or this is a pretty conversational meeting. Feel free to take yourself off of mute if there's an opportunity. You can just ask your question directly. Once we get to the question portion, I will encourage everybody to turn your cameras on. Conversations are always better face-to-face, right? And as face-to-face as we can get today is turning our cameras on. So before I hand it over to our presenters, I am just going to say this learning opportunity is funded by the Bureau of Justice Assistance. BJA does a lot of excellent work in this space of law enforcement and mental health. They support a number of CSG opportunities and grant tracks. So this is in support of their learning opportunities. And that's really all I have for you today, folks. I know you're not here to hear from me, so I'm going to turn it over to our two presenters, Sergeant Scott Stuck and Karen Montano, to tell us a little bit about what they do in Salt Lake City and how they work in collaboration with their Community Connection Center.
Okay.
Karen, you're going to kick us off?
Can you hear me okay?
Yep.
Yes. Okay, great. My name's Karen Montano. I'm the social work director here at the Salt Lake City Police Department. I supervise our community connection team, which is made up of CIT detectives or crisis intervention trained detectives and social workers. We have both case managers and clinicians that make up a part of our team. Currently, let me check my numbers because we've added several new team members. We have 18 social workers and 4 LEOs on our team. And we are very excited to be here. I kind of want Sergeant Stuck to go over a little bit more of like our history. He's been a part of this team for several years now. And so I think he would probably be the best at letting you guys know a little bit of how we got started.
Okay, and I'm Sergeant Stuck. I've been with Salt Lake City for. Am I on mute? No, I have audio. We good? All right. So I've been with Salt Lake for about 18 years. The last 7 have been with my job title here is the crisis intervention team sergeant. Our CIT program is really where it all started. Back in 2001, we developed a training program. Initially, it was for Salt Lake City. We branched that out into a statewide CIT program, so we would teach around the entire state and facilitate other programs. We would run the grants for crisis intervention throughout the state and include trainings for other states as well, including helping other states put together their CIT programs. In 2016, our department hired some social workers through the city council, specifically to help with our homeless problem in the area. Salt Lake City is the only real shelter location in the state of Utah, and it's a fairly robust program for our state. So they were trying to help out with the community partners and created a social work program. We already, prior to that, had the host program, the homeless outreach services team, which was, at the time we hired the social workers, they combined CIT, host, and the social work program, put us under the community connections team acronym. I took the role as a sergeant in 2017. And at that point, we actually went to one of the other training sites, and a couple of them, in fact, to see how they operated. And we were able to see how to implement social workers into their programs. Ours was a little bit different due to the number of officers we have in our program. Some of the other agencies had significantly different numbers. LA, for example, had, at the time, I believe, 150 officers in their mental health team and 50 social workers. Whereas ours was kind of flipped. We had, at the time, 2 host officers and 2 CIT officers, and we had 6 or 7 social workers initially. So that was a challenge initially, was trying to get some more balance in the numbers. That's one of our department failures, is that they went very far in the opposite direction to where we have, how many social workers now, did Karen say?
18.
They're about 18, and I still have 4 officers. So it's a bit frustrating for us on that end, because we could do so much more if we had a little bit better numbering for our social work staff to officer numbers. Anyway, so in the beginning of 2018, we actually combined the homeless outreach and the CIT officers into just one unit. They're all doing the same thing, and combined with our social work team to actually do a co-response program. We kind of learned about that along the way and began implementing that. We had about a 4-month period in 2017 where it was more of a pilot phase, and we tried to work out all the mistakes and all the kinks. So by the beginning of 2018, we had a fairly effective program started. Along the way, we've had to make some other adjustments. The more staff we've had, I mean, it's easier with 7 people to figure out a schedule where you're overlapping. When we got up to 15, there's not enough work for 15 social workers on day shift. So we finally had to start branching that out. We developed some relationships that we had in the past, but not utilized, like Volunteers of America. Here, they do a homeless outreach program, and at the time, they ran the detox facility. In I think around 2022, we started opening a couple of additional resource centers for our homeless population, and they now run one of those as well. Part of the teamwork with our city, they created an MOU that would have the Volunteers of America do a lot of the homeless outreach, and then our team would kind of be a backup to that if they needed help, or if they had issues with safety in an encampment, then we would go do the outreach there. We had a previously existing relationship with our 3 hospitals we have in our city, so that when we met on a monthly basis to discuss some of the emergent and crisis situations that we would have. Some of the same people would overlap with the hospitals, having been involuntary committed. So here, ours is a pink sheet, is what we refer to it as. But they might be sent in from different agencies, or they might be checking themselves in. So we would work with those hospitals to try to mitigate those numbers of interactions. And then our crisis call center, which is now 988. We had a crisis call center, a drop-in center, and our intermediate mental health facility were all run out of the University of Utah. And so we have a pretty strong relationship with them that actually dates back to when we did our initial CIT trainings. So they've always been there, and then we've kind of developed that program better, incorporating 988 into our dispatching. So that way, if you have someone struggling with depression or suicidality, but it's not to the point where there might need some intervention, they just need someone to talk to, those calls that come to us are actually redirected from our dispatch office over to 988. So it mitigates our response to these calls and minimizes the risk of having an officer show up to someone that might actually escalate the problem. Let me think. Is there anything else that I'm missing at this point?
You mentioned a drop-off center, and I'm just wondering if you could talk a little bit about, like, is the Community Connections team, Community Connections Center, is there a physical building that, you know, all of you are working out of? You said that there's host, which then got folded into CCC. The social workers are there. Do they have offices in your PD, or is it at this? Is there a separate building?
Sure.
And like, could you take us through like a standard case that you might involve Karen and her team on?
Yeah. So we've, in 2016, when they created the social work program, they acquired a facility that was across the street from the primary homeless shelter. And so they put the CIT and the host officers in that building. And so that's where initially all of us worked together. When they closed that homeless shelter, they moved us back to the public safety building because the building that we were in increased their prices dramatically now that there was no homeless concerns in the neighborhood. So we spent about a year or a year and a half there back in the public safety building, but with the intention that we were going to move again. So we have another facility. It's just housed for our program. So within our facility, we have the social work team, which consists of therapists and case managers. There's my team. We have actually a few vehicles that have been assigned to the social workers. We have the food bank that is donated. We have clothing donations, and we do therapy. Our social workers have space to do intermittent and short-term therapy before referrals out to longer-term case management. We don't, because our therapists are hired by the department, they can't bill out for services. So we do free therapy, and that gets developed as they progress through gaining Medicare, Medicaid, whatever resources they need to be able to get into that next phase of a longer term therapy, or just get them into the local mental health authority for resources with them. Did I answer all that question?
Yeah, I think so. It's just very interesting to hear, like, not everybody has a separate facility for a program like this. So I know people are really interested in, like, wow, you got a building and you have like a food bank inside, and you have spaces for social workers, not only to do their standard, you know, office work, but then to have clients come in and see them. So I don't want to dominate the conversation by asking questions that I'm interested in hearing. Karen, if there's anything that you want to add to that kind of general overview of the work that the Community Connections Center, Community Connections team does, Now's the time. Otherwise, we can just open it up to questions.
Yeah, so with how Sergeant Stark was saying, we do offer that short-term intermittent therapy, and then we also have our case managers to follow up as well. Basically, we saw the need, like there's this gap in the community where someone might be experiencing a crisis or happen to experience some sort of traumatic event and they don't have immediate access to mental health follow-up and care. And so the thought behind offering that free intermittent therapy, which we were able to do so more now that we have hired so many more social workers, was how do we prevent these individuals from continuing to go back to 911 for those non-emergency, like non-medical related emergencies. And so our whole point in offering therapy is to try to stabilize individuals, either help them process that traumatic experience, or how do we help them stabilize while we get them a referral into a more long-term place. So we know waiting lists can be pretty lengthy, like 1 to 2 months or maybe more. And so if they don't have insurance, we'll try to help them set up with Medicaid and Medicare. And so that's what our case managers will work on, is more of a, let's help you meet your basic needs, while our therapists are trying to help them establish some of those more positive coping skills. We do have, we are associated with our Utah Food Bank, and so we do get our food sourced from there. And then much of our clothing donation closet has come from our own social workers, or we've done drives department-wide to, and officers have been very generous in donating on that end. We do hold a monthly community resource meeting that one of our case managers runs. Essentially, all the crisis intervention or crisis services in the area will meet once a month to discuss our highest utilizers, come up with plans on how can we coordinate our services to prevent this person from continuing to access 911 services for non-emergency reasons. So that might be someone that's diagnosed with borderline personality disorder that keeps calling into 911 saying they're suicidal. Police show up and they say, oh, I was just sad, I wanted to talk to someone. So how can we mitigate those needs without having to keep sending police? So yeah, I guess we fit a bunch of we wear a bunch of different hats here too, depending on the needs. And so any questions you guys might have, I think it'd be great.
Yeah, now's the time, right? So, okay, folks, if you have any questions for the Salt Lake City team, feel free to raise your hand, put it in the chat, come off of mute, and ask directly. We love conversation here. So, wonderful. All right, Jolene, how are
Hey, Ethan.
things?
Sorry, I jumped on a little late. I was working on a project. So I didn't hear everything in the beginning, but I jumped in. I'm probably about 8 minutes late. My name's Jolene Jennings. I'm the Behavioral Health Systems Improvement Specialist at Lewis and Clark Public Health in Helena, Montana. And we been building our Crisis Now model for the 3 pillars since 2021. And so we've been working with our MCRT, behavioral health professionals, and law enforcement as a co-response model since 2021. And that's really in great shape, but we're trying to work on identifying more future planning in regards to data collaboration with the bigger whole of the community in our behavioral health response. We'll be breeding in our crisis facility, which will be the community crisis facility. They are planning to open this fall. Yay, we just got that news a week or so ago. And I've got a lot of coalition meetings going on. So, my mind goes to right now, we're always looking for sustainable funding. So what I heard Scott mentioned was that I believe law enforcement budget was paying for the social workers. Is that correct?
Yes, yeah, it's a city funding, so it was, we were hired, or excuse me, they were hired through the police department. And when the defund the police happened in 2020, they actually took that funding and put it under the city's umbrella.
Okay. But it's, you apply for it for the funding.
Not that specifically. That's for their employment. We actually do
Okay.
have some grants that they do have applied for. I'm not sure what we're operating with right now.
Okay,
Maybe Karen might know what that one is.
thank you. Karen, and also I didn't get a chance to catch your title. What is your, are you a social worker or coordinator or?
Yeah, I'm the social work director. Sorry,
Director,
I'm the
okay.
social work director here at the Salt Lake City Police Department.
Okay.
I'm also an LCSW. So I was in the middle of typing my answer to Jessica's question in the chat, which is similar to yours, Jolene.
Oh, okay.
So like Sergeant Stuck was saying, our program is fully funded by the city. So our city council and our mayor set a specific budget every year, specifically for the social work program. Our funding is managed outside of the police department funding. And we have had grants in the past. Occasionally we will get 1 or 2 grants. But those grants would not cover the salaries for our employees or anything like that. These are just in addition to the budget the city council has already put aside. Grants that we've received in the past have been for like overdoses, so providing naloxone to community members, or doing education around overdoses. We've done, in the past, we've gotten grants regarding transportation, so like bus tokens, things like that, but the city really doesn't like to take on grants like that because they do require a lot of reporting, and sometimes our staff really won't be the best at keeping record of that stuff. And so we have been pushed away from doing more of that grant or getting more of that grant type funding. And so we are fully city funded.
And is that sustainable? Do you have support from the city that says they intend to continue funding this for 3 to 5 years, or is it a year-by-year basis?
The city's been funding the program since it initiated in 2016. So it's a part of the city budget. It's like an expectation at this point, pretty much. They did increase our numbers so we could hire, I think close to 12 additional team members after, it must have been 2021. We were hoping to be available 24/7 with those additional numbers. And then with the creation of programs like the STAR program in Denver, our city council then kind of shifted that direction as well. They took some of our positions that had not been filled yet and put those social work positions in the fire department. So our fire department also has city funded social workers. Their name is Community Health Access Team or Chat. And so we sometimes interact with them out in the field, not too often. Their focus tends to be on more like medical needs. We sometimes interact with them on like suicide attempts, those kind of calls where police officers will call for police social workers and fire will call for fire social workers. But we tend to collaborate pretty well with each other. And most of the time we're both familiar with the individuals we're working with.
And can I ask, do you have, we're looking at trying to create a data sharing system with our partners, which we're, going to expand on for our continuum of care. So as your members for law enforcement, social workers, and other components that you're mentioning where social workers are located, do you have a shared database you use? And if so, what is it called?
So we do have a database where we document on the same database that the officers document on. The only difference is that our documentation is restricted from our officers to see.
Hmm.
So the only officers that have access to our documentation would be the detectives that are immediately working with us, the RCIT detectives that are in our unit. And that's more for like HIPAA reasons. For our therapy notes, we're old school. We document on paper.
Mhm.
So that way it's not in any of those systems. So most of the things we're documenting are just client interactions that we've had, the calls that we're going out on, and if there was follow-up as well, and what those follow-up needs are.
And
Everything
so-
else is typically paper.
And just to add on to that, this getting us to where we're using the same data systems as the police department was about 3 years running of trying to get their own system set up. At one point they were trying to use the fire departments. Another point they were trying to use Access, and each system had its own issues, and what we're using now has its own issues, but at least it's all consolidated at this point.
And the
And so
name of
what is that
system,
system? Is
Scott?
that an Excel sheet, or, I mean, how do you track, I mean, what is that? Do you have a database system that is just an organization's separate, like we use around here, I know they're in development of our law enforcement. They've been doing paper documentation through many of the law enforcement agencies, and they're advancing to something called Central Square. And we have a hospital that has Epic. And so we're trying to find a database. We're looking at Gelada as a database, but that can be compatible with those. So the data sharing can put into that system. And then people who are authorized, HIPAA approved, and they can, and their first responders, crisis responders, the law enforcement, the police department, the sheriff's department, the hospital, mobile crisis response team, they would have full access to all records on information, and it's tracked throughout the system on where the person's been, how many times they've been visited, and what have they been seen for. And I was just looking for something similar to that, maybe that people are using, or it sounds like something a lot of us need.
Yeah, what's the name of your system, Sergeant?
So we use a Versadex.
Got it, got
But
it.
what she's saying is actually a fantastic idea. Our challenge is with 3 separate hospitals. No one's going to share that information with each other, let alone with us. On the law enforcement side, in maybe 5 years ago, we got the entire county on the same system. So we're all on Versadex. We had like 3 different systems prior to that, so you could never see what other agencies were using, when they'd run into the same people. So we've solved that on the law enforcement side, but that took legislation to get that done. So it'd be again the same issue to get that done from the medical side.
Got it. And our next question is from Natasha. Natasha Coate, where are you from and what are you interested in?
I'm from Lassen County Probation. I'm the case coordinating supervisor. So my position's kind of like the first step of probation having a social worker, because I'm an ASW right now working on my LCSW. So the biggest thing that I'm noticing is there's kind of a difficult shift between old school mentality with social work and, like the hug a thug kind of thing versus changing the thought process of that. Is there any trainings or suggestions or thoughts on how I can kind of bridge the gap for these old school officers into the new world of social work and collaborative care?
We ran into a lot of that early on with our program. In fact, the chief that was assigned over us hated that he had our team underneath him. He thought it was all just a waste of money, and so some of it is just getting the right people in there, because we've had fantastic leadership since then. We've had the buy-in from leadership after that, but the biggest thing we could do, being proactive on our level, we started having the social workers go out with patrol officers when we had more social workers than officers available, or if, for example, if we're teaching CIT training, we would try to schedule that time to have a social worker go out with a patrol officer, just so that way they're kind of forced into having those interactions and becoming more comfortable with the idea of having an additional route or avenue to take on a call. And I would actually go with the social worker to the lineup room and introduce them and explain what they're there for prior to. And it was a lot easier getting the buy-in. It still took time. And we were talking probably over a year before we really got it going, where they would start calling us out. But we made sure that they were familiar with it, and we would show up on calls proactively to make sure that they didn't forget about us. And now we're to the point where we could have everybody dispatched out on things and still be receiving requests.
Okay. And then my other question was more financially related as well. I know that you guys have like kind of dual things happening, and I know in some states they're kind of opening up Medicaid billing as an option. Is that something that you guys are exploring? Is that something that you guys are capable of incorporating in addition to your other funding streams for the therapeutic side or the case management pieces?
So we haven't explored the Medicaid piece, mainly because we are funded by the Salt Lake City taxpayers. And so we service all of Salt Lake City and the airport here. But our understanding from the cities that we are not to charge for the service or the services we provide, because we are taxpayer funded essentially.
Gotcha.
That's not something we've looked into. That'd be nice if we could have some extra funds for the smaller things that we don't ever get funding for, but yeah, I understand why that's been set. And just to add to Sergeant Stuck's question, from a civilian standpoint, I think you're going to run into some officers that are set in their way, or think, I don't want to wait here 20 minutes for a social worker to show up in the heat or in the rain or in the snow. And so they'd rather resolve the call themselves and move on. And there are other officers that we interact with that they're calling us back to back to back. We're pretty much following them to the next call. As civilians in this role, I mean, I never imagined I'd be working for police department when I started my career, but we've done a lot of assisting our detectives with the CIT Academy, where we'll show up on the day that they're doing role plays and we'll play out the role of the client. We help out for our police academy. There's a 16-hour mental health block that our social workers will teach, and that gives us an opportunity to meet the recruits in the academy. And then we get to see them after they graduate and interact with them on the street. So it's been pretty good experience, I think, getting to meet them before they're out on the street. So they get to meet us and build a relationship.
Is that mental health block like mental health first aid kind of services, or is it more like in-depth about specific diagnoses, and like what type of training is included in that?
You're both on, one of you's got on mute. There we go.
Yep. Yep. No, I was on, I had my speaker off for that second, so I didn't hear the full question. So Karen was catching me up. Yeah, so we do it's basic CIT Academy covers the broad spectrum of mental illnesses with the focus on the ones that police are most likely to interact with. Like your schizophrenia, autism, depression, bipolar, things like that. We do role plays throughout the week. My personal focus for the entire academy is to make sure that we're building empathy for the officer. So we do several different interactions with people at varying stages with their mental health. We go to the state hospital. We meet people that are incarcerated. We talk to people that are in the midst of crisis. So they're at one of those early level stages where, so we have here, it's the involuntary commitment goes to the hospital, And if the person is not stabilized there, then they might extend them to the University of Utah. It's the Huntsman Mental Health Institute. So we go there and we might meet people there as well. So we try to get a broad spectrum of experience for these new officers to it, as well as teaching them what it is so they can recognize it when they get out on the street.
Hey, Ethan, can I pop in with a question real quick?
Of course, Ernie.
Hey, Sarge, let me, or Karen, first of all, thank you all both for being here. Very informative. You know, when we talk to people that have a co-response team like this, we hear about the good training that the officers get with CIT, but do you have an actual curriculum, or what kind of training do the actual social workers get that are embedded with these officers to go out on calls for service? I mean, like, do they know how to apply a tourniquet, scene safety, things like that? Could you walk me through what some of that training looks like?
Yeah, so we put them through the CIT Academy. They have their own 2-week block when they first come in, where they go through radio training and approaches, so door approaches, going to houses, responses. If something happens, what are they supposed to go? What are they supposed to do if an officer has to take action? We've done some additional developmental trainings with firearms. So we have them in their initial 2-week block. We teach them how to handle a firearm and shoot it, so they know what to expect of it, and they know how to deal with it. And then we teach, what do you do with it if an officer is disarmed? So they've got those additional steps like securing it, things like that. We also encourage, they work with some other entities. We'll get them with dispatch, our victim advocates, things like that, so they have a broader knowledge of what the police department does and how they operate. They operate off of our same policy manual and our procedure manuals. I don't know if there's anything else, Karen, you want to add on that? Sure.
So I'm curious,
So,
right?
we
because work-
basically, we started doing this training schedule every time we have a new staff member come on. So that will not only include kind of policy procedure stuff, and like Sergeant Stuck mentioned, we'll have our CIT detectives spend several hours with them in those first 2 weeks to go over safety, scene safety. I had never discharged a gun until I started working here. And so basic things like that. We have had some tourniquet and pepper spray training. Do not recommend that. And so I think it helps for bonding, but yes, pepper spray is very painful, especially the grade or the level that they use here.
So that leads me to something, right? Because I'm curious, because you're employed by a police department, I could see why the police department would put an emphasis on training. I'm wondering if anybody else on the call who's a clinician that's not working for a police department, but maybe working for a local mental health authority or treatment facility, do you have any kind of curriculum that you had to follow? Because I truly am interested to seeing what kind of training clinicians are getting to ensure that as we help agencies build out these co-response systems at the Justice Center, that we have every resource possible to keep everyone as safe as possible. So I'd be curious even to hear from somebody that's on this call, that's a clinician, to hear about what, if any, training you got. And if you didn't get any, I'd like to hear that as well.
Okay, we have Natasha responding in the chat. Anyone else?
I would say Natasha's response is pretty typical, I think, of a lot of therapists. Specifically, like, there are many people on our team that we've brought over from Child Protective Services that were never given formal trainings on even how to knock on a door, not knocking straight on the door, but to the side, and things to look out for. All those things I think we've been learning as we shadow our officers and we shadow the senior social workers that are here. I think creating a curriculum would be great for sure. I think additionally too, for safety reasons, we also wear ballistic vests as well. Our uniforms will say social work on them. Our jackets, our vests have patches that say social work, just to try to distinguish us from our law enforcement partners.
And Karen, question for you. So you said that you have a uniform that you're going out in. Does the ballistic vest also have like one of those patches on the back, or is it just written on the vest itself, like social worker?
The vest will have a social work patch on
Okay.
the front. We wear them over our clothes so they're not hidden underneath our clothes, mainly because we're coming in and out of the office all day. We're responding to calls or coming back to appointments, or taking our breaks. But we also have a patch on the back of the vest. We have jackets that will say social work, and it's kind of like that reflective material. So hopefully people will see us. We have radio training and shadow dispatch officers as well as some CIT from Bailey. Yes, I think when I first started, our radio training was very minimal. Since then, we do have officers sit down with our social workers to go more in depth because we are radio responsive.
Excellent. Yeah, that's helpful to hear just because I hear from people a lot being worried about, well, if we give our social worker a vest, is that then going to make them look too similar to our law enforcement folks? Are people going to confuse them? How can we really make it super clear? You know, I've seen people write social worker like in all caps in bright blue across the back. Sounds like yours is a little bit more subdued than that, but it is still a pretty decently sized patch. So yeah, just nice to hear that. Nice to hear that you're considering all those safety concerns and taking the right steps about it. So we've got a couple of responses in the chat about clinician training. I do see a couple of people who look like they're ready to ask a question. If you have a question, feel free to use that raise hand feature. And I do have one that came to me directly in the chat. So the question I'm seeing here in the chat for you, Karen, is when working with the Community Connections Center and referring out, how long do you keep a client working with social workers employed by SLCPD versus referring to your external partners, and what does that process look like?
Yeah, that's a good question. So we typically say that the short-term therapy that we're offering is anywhere from 6 to 8 sessions. So during that time, so that'd be about 6 to 8 weeks, we're trying to get individuals on a waiting list or into another provider. Since we are able to offer these services for free, we can be flexible with that. If there's some barrier to be able to get them into a different type of program. Sometimes when you're working with individuals that don't have the appropriate documentation, they might not qualify for Medicaid. We might keep those clients on a little bit longer until we find a program that's like a pay scale or some sort of free or lower cost community program. How long do we keep them? It really just depends. And there's a lot of clients like our frequent flyers that continue to come back to us periodically. Like maybe we got them stabilized and then a year later they're getting evicted from their apartment and they're off their meds, and so they're destabilized, and so we might meet with them again for a couple weeks to get them back on track and maybe find them new housing. So sometimes we're finding people housing every year, depending on their experience.
And looks like Rebecca's got a question.
Yes, hi. Thank you for this. Seems like such an awesome program, and I'm really, really glad that Salt Lake sees the value in funding it. My question is kind of around funding and people's perception of defunding the police versus, having other social workers and stuff take over things that the police have done in the past. I recognize that you all get funding separately from the police, but I wonder, I remember with the defund the police movement in 2020, there was a lot of pushback with that idea. So I wonder if there was any pushback when this started in 2016, which with the idea of, do we want to put money towards this? And kind of how it got started. Was it something that was advocated for by the mayor, or who was the driving force of getting this started in Salt Lake?
It was actually one of our assistant chiefs at the time, going back to 2016. We were having a pretty heavily invested effort from the state to try to mitigate some of the homeless problems we were having in just one specific area of Salt Lake City where all of the resources were. It was pretty bad. I mean, if you've been to major cities, you've probably seen similar or worse. But for our city, that was the focus, and the state finally stepped in, gave some money, gave some effort, gave us some law enforcement assistance as well. And so there was a very, very big push, because it wasn't just trying to arrest our way out of the problem. That was the mantra at the time, was we can't arrest our way out of this. So they had to start adapting. And this chief came forward and said, why don't you give us some social workers so we can really do something on the floor level? So we got an initial group of about 4 was the first hiring, I believe. And then it kind of expanded a little bit as they were seeing some real use of them. And then we reached a point where they were solely just managing mail and drop-ins for just a small number of people. So most people were not showing up for appointments. And so we had to start going out. And that's really where our evolution began, with our co-response was going to find people who weren't coming to us for those appointments. As we approached 2020, as just about everywhere, we were having problems with the defund. And that was kind of, I mentioned earlier, that was kind of the magic, look over here while we do this over here. The money was funded to the department for the social workers. And at that point in time, they took that money out and just put it in the city's general budget. So once they did that, they could say, well, we defunded by this much money, without actually taking any resources away from the department. So we were very fortunate that our city saw the problem and didn't react the way that we had a lot of the public responding. I had to speak at several meetings about trying to expand the social work and the CIT programs, because we had a lot of people during the defund that were trying to figure out where's the value with this department, where's the value with other departments around. And so they all recommended we actually give more officers to this unit. And that's where we ended up with social workers, because the city had a little bit more pull and leverage with that than they have with officers, because they can't just say, we want more officers, hire more officers, because it just doesn't work that easily. Whereas you can say, here's the money for social workers. Let's take the time to build that budget up.
That's fabulous. Thank you. Do you know how common these kinds of programs are becoming? Is there a spread? I hope so.
Yeah, I don't know, but it's certainly, from the time we started, we were learning about it on the fly. And with the program that we're part of with the BJA, all of these different training sites across the country have been very, very busy with questions and site visits from other entities that are trying to build their own.
Awesome.
Yeah, and if you're curious at all about some of the sites that he's talking about, I did just put the link to our website in the chat for you. So that's the 15 law enforcement mental health learning sites. But then I was also going to say that there is, just in terms of kind of your comment, Rebecca, about like is this happening around the country? What is the kind of, I don't know, I guess permeation, like how common is this? Is everybody doing this? So another thing for you to keep in mind or to be aware of if you're unaware of it currently is the JMHCP grant track. So Justice and Mental Health Collaboration Program. This is a grant track that is funded by the Bureau of Justice Assistance, which is the grant making arm of the Department of Justice, like the Federal Department of Justice. And so JMHCP funds, I want to say between, like, off the top of my head, I want to say it's between 30 and 50 grants every single year of about $500,000 each. And so if you apply for one of these grants, they're 3-year grants, you can get that $500,000-ish, sometimes more, sometimes less, and then implement one of these programs. So at the start of this meeting, I mentioned that in addition to my work with the learning sites like Salt Lake City, I do technical assistance for grantees. I have 20 teams around the country that I work with at any given moment, making sure that these grants that they applied for and received end up as successful programs. A lot of them are co-response based, or we have some that are more community response, some that are about embedding mental health staff into 911 dispatch centers, all different types of stuff. So JMHCP is a pretty big umbrella for funding these types of collaboration programs. If you haven't looked into it, I would highly encourage you to do so. It's every single year they put out a new solicitation. So if you want to put together a grant application, I think the next round is probably in May of 25, will be the due date. So yeah, that's there is definitely a lot of this happening around the country. It's not just these 15 sites, but you know, there's a lot to learn about. There are tons of things happening, but they are excellent examples. And that's why we have them on, you know, that's why we're facilitating these conversations.
Great. I will definitely look into those. Thank you.
Absolutely. And feel free to follow up with me. We can talk about grants anytime.
Great.
Heidi.
Hi there. Yeah, so I'm in Metro Detroit in Michigan, and we work with county level partners around community mental health and law enforcement, primarily in the jails. So my question is, we do like technical assistance and evaluation, primarily for grants that come through the state. So my question is, does your team ever work with reentry and discharge with the jail folks, even if it's familiar faces to your team? What does that look like? And then also, do you have a partnership with your community mental health agency more directly?
Thank you. So we are not involved with the reentry from the jail. I know Salt Lake City recently started and hired a social worker for their justice court. And I think that program's being called Friendly or Familiar Faces. That's what it's called, Familiar Faces. So essentially that social worker is in the process of creating and establishing a program there to try to see how can they help individuals get their basic needs met and not go back to jail. And so that program's just barely now in its infancy. And I forgot the second part of the question.
I was just saying, I was asking if you have a partnership with your community mental health agency. And in Michigan, we have generally, each county has its own community mental health agency, and I'm just not sure if that's universal. So that's usually who we're partnering with, and they're often the provider in the jail. And so that's why, like for the behavioral health. And so that's why, just curious, because oftentimes they're also the partner for these crisis response teams that we're learning about in Michigan.
I'm sorry, Heidi, could you repeat that again?
So yeah, the community mental health agencies in Michigan operate at the county level, and they're generally contracted as the behavioral health provider in the jail. And so because of that relationship, they're often connecting to folks on that discharge piece and on the crisis response piece, because those CMH clinicians are often the partner in these crisis teams. And so I was just curious if in Utah, you all have that similar model where CMH, community mental health partners, if you have a county level agency, so that those social workers at the community mental health are partnering with the social workers that are city funded. Is there a relationship there? Or is that even how you're community mental health is structured?
So we have just one big, well, like the main provider here, Valley Behavioral Health, is the contracted provider for the county. We do have a relationship with them where we have them regularly attend some of our meetings when we're discussing some of these high utilizers and how we can best get them back into services. Most of the time they've already been receiving services, but maybe stopped going for whatever reason. But outside of that, we don't really have a relationship with that provider directly. I know our jail does have like a release program that's run by the county where as people are coming out of jail, they're being offered services or they're trying to see what their needs are, but it's completely voluntary. I think here in Salt Lake, that's something we could definitely work on, is not be so siloed, but I think a lot of times the concern comes back to like HIPAA and how are we sharing information? Are we doing like, are we coordinating for care, or would this be considered something else? And so we run into those problems quite a bit with some of these agencies.
Thank you.
And I see a hand up from Kyle. Kyle, where are you from? What's going on?
Hey, yeah, I'm in Cape Girardeau, Missouri, which is about if you drive from St. Louis to Memphis, you'll hit it about halfway. So it's not a huge jurisdiction. The city is somewhere around 40,000, the county somewhere around 80,000. So I just wanted to piggyback on some of those other things that individuals were saying. We just finished with our Connect and Protect grant through BJA. And we went in with kind of the agreement, if we can prove that this is effective, then the city will, our chief of police was able to sell it to the city to get the funding from the city, because we were able to show just how good the outcomes were. So that really goes back to really having that good data to be able to prove that what we're doing is effective and works. And, you know, we cut officer time on scene down. And what we did is we embedded 2 behavioral health professionals in the Cape Girardeau Police Department. So basically a co-response program. So, you know, we cut officer on scene time from like 62 minutes down to like 12. Right, whenever it was a mental health call. So, you know, if you keep your good data for those that are looking at doing something like this, that's huge. And that's a huge selling point whenever you're talking to the city. Because let's face it, I don't know if there's a department in the country that doesn't have issues with hiring, right? Everybody's short-staffed. So if you can take a mental health professional, behavioral health professional, and that take the place of a couple cops, then you're doing yourself a favor to be able to do that. So actually that grant system's a great way to be able to get started for departments. I work at the Community Mental Health Center here in Cape Girardeau, and so we wrote the grant. PD was on board. Sometimes cultures clash a little bit, but we were able to make it work. It's an interesting environment, and then to the point of, you know, how popular are these things becoming. I went to the National Co-Responder Conference. I was just shocked. They had like over 900 people attend. So I'm not sure who was asking about that. Is this happening everywhere? Yeah, it's happening everywhere. I didn't even know it was that big. The other thing that we started, the last person asked about jails, we started what we call a jail navigator program. So we put a licensed professional counselor in our county jail who can do assessments on people as they're there. And our goal is, our unofficial goal is, if we can get them assessed and started on meds before the state government realizes they're incarcerated and we can get Medicaid to pay for their medications. We're going to do it that way, right? And then they assist on, these are for the people who we know that aren't going to go to DOC or not going to be in there for a long time. And then we can assist on that follow-up. We'll hook them up with a peer or something to follow up upon release, so that they can continue its services. And as our jailers say, I'd much rather have a medicated inmate than somebody that is hallucinating and delusional and all that kind of stuff. So just want to kind of throw my 2 cents in there.
Yeah, I appreciate you sharing. And I put the link to the International Co-Responder Alliance in the chat for everybody because I was there too. Yeah, it's an excellent conference. I went for the past 2 years, and lots and lots of really interesting stuff getting shared at that meeting. Tons of people just, yeah, sharing what they have, what they've learned, and all their different program models. So anybody who's interested in this kind of stuff, ICRA is a good organization to join, and definitely a great conference as well. And yeah, thanks so much for sharing, Kyle. Really appreciate it. Actually, your colleague was on our virtual symposium the other day. Corporal Rogers was
Oh yeah, well, yeah, he probably went over the data system that he developed to capture
Yes.
the information, and he built that. You know, we had something, you know, it was always that difficult thing. We can't share information because of HIPAA, blah, 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 blah. You know, cops don't care about HIPAA. So they'll share whatever they want to share for the most part. But he built a system, and it did really well at being able to track those data points. We had something similar in the earlier points, but we had it through our Microsoft platform that he couldn't get into. So
Right.
then that limited his ability to be able to track the data, because those key points of things like that officer time on call is a big deal. And so we're able to track those data points better so that we could tell that story, because that story is where you're going to get your funding.
And you brought up something really interesting. And Heidi, I'm going to get to your question right after this. I just wanted to ask our presenters. Kyle had mentioned that sometimes there are some culture clashes, right, between social workers and law enforcement. And I wanted to ask you both, how helpful has it been to have your own space? There's a separate building that you're working out of. Was that kind of, was it great, or was it a challenge at first because, wow, we're all contained under one roof and we're not totally getting along right now? Or was it, well, there's no breathing room, so I guess we're friends now? Like, what was that like for you? And would you recommend for other people, if the opportunity presents itself, if there's funding, to go this same route and have kind of a standalone building for these type of collaborative efforts?
Yeah, I've found it to be valuable to have everyone under the same roof. For one reason, there's almost an indoctrination for social workers coming in, getting used to how cops speak to each other, how they might treat you when they feel that camaraderie with you, the things they might say, the shocking things we might say. And then it actually really helps to get a better understanding of where the social worker is coming from, because most of the time when we've had social workers come in, they just hit the ground running and they're on the same playing field with us. They've seen awful things. They've had to do awful things, just different ones. And so you can relate. And occasionally we'll get somebody fresh out of school or has their own goals and thinks they're going to overturn the entire system. And those are the people that usually don't last very long. We've had a few of them over the time, but for the most part, we have a really good crew that comes in and just right away hits the ground running. So some of that's probably because we're really, really great interviewers. I don't know, but it's important, I think, to build a relationship, because it's hard for our social workers when they go on a call with a patrol officer they don't have a relationship with, And if that officer is just gruff or grumpy, they can't call them out for it, and they can't really resolve the issue they might want to. They may not be able to push back or argue the case, which is the importance of having the co-response team, because if there's a disagreement, the social worker and one of my officers can actually have a discussion about it, and they might come to a decision that the officer might not have agreed with, but was able to defer to the social work staff. Whereas if it's a patrol officer, I've heard too many stories involving one of our other programs. The Huntsman Mental Health runs a mobile crisis team, so they send social workers on crisis calls, and officers can request them as well throughout the county. And I've heard times where they've wanted to do an involuntary commitment. They have a great deal of background information on the individual, and our officer just doesn't agree with it because of what they're dealing with right then and there. And so their social worker can't have that conversation with our officer. They should be able to, but that's that kind of culture clash. We don't want to be told what to do, and they don't want to be told no. So we get that kind of back and forth. But when we're on the same team, it's a lot better and a lot more effective.
Karen, anything to add from the social work side, like just in terms of having that space? Because like you said, I'm sure for a lot of social workers, oh, I work for a police department is kind of I didn't really expect to be here, but now I am here. Can you speak to that at all about like being in the department itself with everybody else in patrol versus being at your location where it's really just the community connections team?
Yeah, I feel like when we were previously in public safety building, it was kind of intimidating to be in the second floor with all the detectives. So it's like our detectives floor. And sometimes we'd run into issues like we needed private meeting rooms to meet with clients, and they were being in use by detectives doing interviews for victims or something. And so we had some issues when it came to like finding the appropriate meeting space. Additionally, because we had things like the food bank and our clothes closet, we had to store those in some weird corner of the public safety building. So by the time the client came to the door and then I got called by the front desk, I was able to walk down there, go to the closet, come back. Oh, I forgot the key. That whole thing, it'd probably be like 45 minutes that this person had been waiting for some socks or something. But it is nice having our own space. I think it gives us an opportunity to kind of get away from some of the well, I think with 2020 morale was low, I'm assuming in a lot of police departments. And so it was a lot to have to be in that space with, you know, all these officers in this massive building with all these law enforcement officers to have to take on their stress and their anxiety and stuff like that. And being in the separate building kind of helps us be able to recuperate from some of the calls that we go out on. But also it kind of allows officers to have another space that they can come to that's not so full of like administrative mumbo jumbo. I don't know how else to say it. But just having the man kind of lingering. And so we welcome officers to come and hang out with us, to have dinner with us when we're on shift, or to come eat their lunch with us. And so that's been really nice, I think, for helping build those relationships and building rapport with officers. I think that's what it's ultimately about, is building a relationship with your coworkers, essentially. And so, and once you build that relationship, it is much easier to have conversations when you're having disagreements as to whether or not this is going to be an involuntary commitment or not, whether or not the officer should take custody of a child in a suspected abuse case, things like that. And so it is really nice to be able to have those conversations with your coworkers who hold a lot of power.
Well, that's really excellent. Thanks so much for sharing. I'm sure a lot of people would like to have that kind of separate building and space for themselves as well. It sounds like it's been really, really useful just in the development of your team, in the gelling of everybody, just so that you're on the same page and really feel comfortable with one another and trust one another in going out on these calls. Okay, I'm scanning the chat for questions. Anyone feeling brave want to come off of mute?
I was looking
Okay.
at the chat, that last reiterating Kyle's point around the importance of data and building buy-in. It's still a challenge for us because of the way that our data systems are put together and working together with the county. A lot of the stuff we have doesn't get accounted for. So we actually have to do a lot of manual data collection for our unit. So number one, it is typically less accurate than you might have if you're doing it through the computer systems. But with that, we're able to track some things that we can go back to the city with and show where there's some value that they don't see. I have my officers track the amount of time they spend on the phone with people that are calling them directly rather than calling dispatch. So in a typical week, we might save, just from doing that, just phone calls, returning phone calls and letting people call us and leave voicemails can save upwards of 2 hours, which isn't a lot, but it's a lot of time if every one of those people is calling and requesting police to show up. So for us, 2 hours could be a full day worth of hours for the number of officers that might show up. And then back in 2017, we did a case study on one of our clients where we followed them over a period of time, took the averages of the number of calls and prior to us getting involved with this person. And then from that time forward over the next year, and we were able to quantify the amount of money saved by having our team there to engage with this person, as well as the number of hours saved from officers. So we had to be a little bit creative, and I think it's valuable in those situations where you maybe don't have the robust data system for collection, that you find creative ways to be able to still show that there is that very effective way of doing what you're doing.
Absolutely. And that actually, it brings a question to my mind about when you're doing co-response, or actually, I'll start with this. Karen and Sergeant Stuck, I think you may have mentioned this, but I'm forgetting in this moment the shifts that your social workers work. Are you on a 24-hour schedule? Is there a break in the day that nobody is on call? Like, how's that work out? Because I know for a lot of people, one of the things that they track initially is sometimes they'll create like a ghost car or like a ghost team in the CAD system so that, well, we don't have a social worker on right now, so we can't send them to this call, but we'll assign the ghost car and a real car so that we have numbers showing this is how many calls we would have sent somebody on if they were working this shift. And I know a lot of people use that at the beginning of their grant or the beginning of their program just to justify, like, hey, do we need somebody to work this hour? Do we need people on at this point? What is the need, the level of need in our community? So I don't know if that's something that you've employed, but more than anything, I'm just curious, like, what are the schedules for your social workers? Because you have a lot of them. You said you've got more than you probably that you can put on day shift, right? Like, there's not enough work to go around. So how did you get, what are the hours? And then if you do have people working overnights, how the heck did you get them to work overnights?
That is a good question. Thank you for the idea of the ghost social worker. We do not currently do that. I know our officers can request social workers, and if we're not available, the dispatcher may put that in the notes. We're supposed to be able to search and like do a word search to identify how many times we were requested. I don't know that that actually does happen though. That's a really good idea that I will propose. So our social workers, 18 includes the 3 supervisors and myself, the director. So, oh, thank you, Stuck. We also have 1 social worker in the sex offender registry, that I always forget about because they're not in our same building. Sorry to Tim, who's not on this call. But basically, our social workers are split up into 3 different teams. So we have a Sunday, Monday, Tuesday, Wednesday, Thursday, and a Thursday, Friday, Saturday team. Originally, we tried to have a team do Friday, Saturday, Sunday, but found it really hard to get any staff to work the full weekend. And so we split the weekend up. And so we were able to find staffing for those. We're currently available 8 a.m. to midnight, 7 days a week. And so we do have a gap in services from midnight to 8 a.m. And we've heard from different grave officers that they'd like for us to be available specifically on the weekends. It seems when there's more chaos or crises happening, maybe there's like a drunk individual, didn't have a good night at the club, and maybe now they're having some suicidal ideation. But because we were supposed to be available 24/7, but with the city moving those open positions over to the fire department, we weren't able to fulfill that. And so maybe at some point we'll get the numbers to be able to provide for graves. But currently we have, between the 3 separate teams, we have a day shift and an afternoon shift. So a day shift will be 8 a.m. to 8 p.m. and an afternoon shift will be noon to midnight. Basically, we wanted all of our teams to be able to overlap in some sort of way, and for also the team members to overlap as well. So if there's anything that the outgoing people need to pass on, they can, and vice versa. We do have them all do a 4-hour shift on a separate day. So we allowed staff to choose whether or not they wanted to do 14-hour shifts or come in for a separate 4-hour shift. They all voted to come in for a separate 4-hour shift, which was great for us because that's when we schedule our team meeting. So they're all able to attend and be present for that meeting, and just finish up any case notes or anything like that that they need to have finished before they either start their full work week or ending their work week. So, but yeah, it's been really good, I think, to have us available. And there's many times where our crew that comes off at midnight will still be on at 1 or 2 in the morning. We allow them to flex their time if they want, or we do have some overtime funding that we're able to use. But that's how we are currently scheduled.
That's super helpful. Super helpful. Appreciate you sharing. All right, folks, we have about 10 minutes left. I know we've covered a lot of ground today, but this is your opportunity. We've got time for a handful more questions. If anybody's got anything, now is the time. I'm going to put myself on mute because I know I jumped in and asked like 2 or 3 questions already. So I'm going to sit back, let you raise your hands.
I can pop in with a question. So my name's Bailey. I am a mental health professional embedded within the Rochester Police Department, Olmsted County Sheriff's Office in Minnesota. My And so my question, I know you've mentioned kind of having the 4 Leos that are directly embedded within kind of that social work team. And then you've also mentioned going out with patrol. Can you explain a little bit of the difference between when you respond maybe with one of those assigned Leos within the team dynamic versus what the dispatch looks like for a team or for a patrol officer?
Yeah, so typically if it's an officer from our unit with a social worker, they're going to volunteer or self-dispatch and head to the call. If and that's that they actually may already be out because they do follow-up as well together. And so they organize that before they go out for the day and might be doing that as well. If it's an officer from patrol, it's typically a request made for a social worker to help out. And so they'll get over the radio and request that, and whoever's available will head that way. If we actually have an officer with a social worker, we still would prefer they go, and with the hopes that we can relieve the patrol officer on the call to go back and move on to other things.
Perfect. Are you all responding to primarily mental health calls, or do you respond to other calls that officers, like the general patrol officer, would go on as well?
We primarily respond to mental health calls, and then a lower priority for us is if there's a homelessness issue. So we do like the social services types of calls. We won't respond to other calls types like domestic violence, robberies, things like that. We don't respond to those types of calls unless we just happen to be in the area. We've had a few incidents where guys driving through the city shooting a gun off, and our officers end up getting in the pursuit with social workers in the car. And this was very early on, and I had to pull them aside and say, what are you doing? This is before they had to share vests. They didn't have their own vests yet, so we had some issues early on with that. But in general, no, we don't respond to other types.
And just to add to your question, or what Sergeant Stuck was saying, so our CIT detectives are day shift and work 4 days a week. And so with the abundance of social workers and our extended hours, we started going out to requests from patrol to help meet that need. We do still expect patrol officers to stay on scene with us. And that's usually because there is some sort of history or some safety concern. And then most of the time we'll be getting called to all sorts and different types of calls that might not have come in originally as a psych or a mental health call. And so there might be like a domestic occurrence, and after the officer gets on scene, receives different information. Maybe it's a youth that has autism, and the parent doesn't know what else to do and is experiencing caretaker fatigue. And so we might then get called by the officer to come out and see what kind of resources they're already accessing, maybe where we can help fill in the gaps, things like that. But we've been called out to all sorts of weird calls. We'll also pay attention to the calls coming into dispatch. So if there's an address I'm really familiar with or a phone number I'm familiar with, I'll look at the description, and maybe it's a client that's reporting that the neighbors are spying on them and, you know, hacking their calls and stealing their mail. I might then reach out proactively to that person over the phone, see if we can resolve it over the phone before sending out any officers. And if I'm able to clear the call, then I will. So we have responded in that way too, to kind of divert some of those calls from patrol as well.
Do you have any idea data-wise, like what your percentage is of field response versus a phone response?
Can you repeat that again? Sorry.
Yeah, so just kind of wondering like what your data shows for how often or what percentage of the time you're responding in the field versus being able to alleviate over the phone.
So we're not able to track some of those diversion efforts. And so we currently have our staff self-report. And so we're having them fill out either like a spreadsheet, or some of our older staff prefer to hand over a piece of paper with how many minutes they spent on a call and saved that time potentially from dispatch or patrol. I would say the majority of the time we're responding out. If I gave you a percentage point, I would say probably like 70% of the time we're responding. Because sometimes we might be out in the field already and we weren't able to catch that call coming in. Or usually those types of calls are lower priority. So we might not look at those first because they might not pop up on the screen first. But in general, most of the individuals that we meet that we know are calling into 911 frequently, or officers will tell us, hey, are you aware of this person? I've gotten 10 calls on them this week and there's nothing going on. So we might then make an effort to go do follow up with our CIT detectives to give them an alternative to 911. And so we'll get text messages or phone calls. We had one case manager that received like 500 text messages in one weekend from an individual, and as long as she gave him a thumbs up occasionally, he was fine with that response and wouldn't call into 911. So it kind of depends on the individual.
All right. Well, thanks for the question, Bailey, and appreciate the answer, Karen. We have 2 minutes left. If anyone has a final question, now is the time. Speak now or forever hold your peace. Just kidding. You can reach out to Karen and Sergeant Stuck anytime. They're one of our learning sites. Their contact information is on their website. So if you do come up with a question later, don't feel bad about it. You can always email them. But Austin, I see you came off mute. You got a question?
Yes, I did. Just really quick, going back to your discussion on kind of like screening some of the calls, and if there was something that you can do prior to it actually being dispatched out. With that, do you guys do any other like proactive follow-ups, or just going back out periodically, just checking on some of the familiar faces, if you will, just to kind of just see what's going on, see if they have connected to some of the services that you have initially tried to connect them to? And then if you have, are there any like success stories that you hear coming out of that, or anything that they have like shared to you about just this entire process?
Yeah, so we have a few different avenues where we can end up with follow-up to be done. When an officer responds to a call, they write a report that gets routed for, if it's mental health, it gets routed to me. From that point, I'll send it to one of my officers for the follow-up. So we've got that piece where they'll be doing follow-up with the social worker for those cases. But in addition to that, we have any of the cases that they respond out to as initial officers with our social worker, as well as anything the social workers get referred to or requested to by patrol. You've got 3 different options right there where an officer on our team and a social worker might find themselves doing some additional follow-up. And we'll try to keep regular contact with someone if it's someone that continually has issues, if it's more of a one-time thing and it can be referred out, or sometimes we get someone who's suicidal over a breakup or something like that, and it's just the one-off. We may not do much follow-up with that. However, when we have someone with a chronic mental illness, that's someone we'll probably keep on the radar and keep working with regularly. Our social workers might continue therapy in the interim, things like that. And then you asked about success stories. We've had some that we'll be able to get them from where they're borderline homeless, or in a few individuals' cases that we've had getting evicted from their residence, and our team can go out and help them get move into another place, and just continue that relationship with them. So rather than be evicted and be back out on the street, they have somebody that they can reach out to, and we can help and try to find the next avenue for them, quite often the next housing option for them.
All right, well, folks, thank you all so much for being here. We're at time for today. I know everybody's got lots of stuff to do, so I won't hold you, but thank you again so much to our two presenters, Sergeant Stuck and Karen. We really appreciate you taking the time to share your expertise, share your experience, talk to us about the Community Connections Center and the Community Connections team. For those watching, this was a recorded session. It will be uploaded to the Ask the Expert webpage in about a week or so. So if you missed anything, or if you thought this was really excellent, want to share with your project partners or other people in the field, just wait a week, check back on the website. The recording will be there. If you have any questions, feel free to follow up with myself or two presenters. Like I said, on that law enforcement mental health learning site, there's contact information for both of them. And thank you all so much for being here today. It's always wonderful to get to talk with people in the field who are excited and interested in this work. So thank you all very much. Thanks again to our presenters, and I hope everyone has a wonderful day. Take care.